Hello and welcome. It is Friday. Phew. And my name is Julie Hirschberg. I'm a neurologic physical therapist, the owner and founder of Reactive Therapy and Wellness here in the Los Angeles area, and joining you live to talk about all that we're doing and learning here at Reactive. A lot has been on dystonia recently because we are preparing for our mini course. This is an update of a course that we did many years ago. So we've been really diving in deep into different things, and I've been getting a lot of great questions, especially from our Brain Bites community, asking about different treatment approaches for dystonia, specifically to sensation. And so I just want to reintroduce, if you've missed us lately in talking about dystonia, this is our pie chart. Similar to other pie charts that we use in other disorders, but this has some of the specific evidence and recommendations in dystonia. So we're going to focus on this sensory part of the pie chart, which is kind of like that Kelly green color. And what you'll see is that it lists several different areas that have been shown in the literature or from clinical experience to be helpful in sensory treatment as a part of an overall treatment approach. By the way, I don't just recommend doing sensory pieces. I also really think that it's important that the sensory treatment follows a really good assessment. Like, you don't want to treat sensation if it's not the issue. And also, by the way, I'm going to actually demonstrate things today. I got my TENS and vibration and things. There are contraindications to some of this as a treatment. And so if you're a person with dystonia, you want to consult with your therapist to see what is right for you. For everything that I'm recommending that might have a great effect in dystonia, it could also have the opposite effect. And there's a lot of trial and error that goes into this when we test and treat it in a person with dystonia. But specifically when it comes to putting TENS and electrodes and things like that on your body, you want to make sure there's no contraindications. So let's dive in. So again, we're in the Kelly green portion here of the pie chart. There are various areas that can be really helpful in the treatment of dystonia, anywhere from discovering a lot of different sensory tricks. That's part of the diagnostic process of dystonia, using vibration, using tactile localization. I'm actually going to demo that on my arm today. Practicing kinesthesia, differentiating between different modalities, changing the overall sensory experience. So weighting, for example, is a really great way to do this. Vestibular training, remember our vestibular system's part of our sensory system. Really, really important, particularly when it comes to cervical dystonia or dystonia in the trunk. That might include otolith training. And then TENS. So there have been some really small studies using TENS in the treatment of dystonia. This is one of the ones where I will say it's something that we might trial on a lot of people. And for some people, it can be very effective. For others, no difference. And for even others, it makes things worse. So I'm going to start there. I'll stop sharing here so that I can show you. So by the way, if you're not on our newsletter, I'm going to put a link to all the resources and the things that we use. So in case you're a therapist interested in some of these things, I'll link them up. So we use a really inexpensive TENS unit. You can buy it on Amazon. What I like about it is that it has a lot of adjustability. I think that's important in TENS. And in the world of dystonia, we would typically put the TENS on the muscle that's most dystonic. So I was thinking I might do my sternocleidomastoids, and what we typically do is actually use electrodes based on the size of the muscles. So these are just what I have here at my home office. I might actually go a little smaller, but it depends on the area that I want to get at. We're not going for a muscle contraction. We're just going for a change in the sensory experience. So I'm not stimulating the muscles here, just putting them on from a sensory perspective over the sternocleidomastoid in this instance. And then I will simply turn it on to a really very, very low level that is just barely perceptible. And I like to do this setting so that it's not continuous, but that it's variable, because that is one of the things that we're looking to change is the sensory input. It's really nice to not have the person accommodate it too quickly. So I'll turn it up just to where it's perceptible. I'll put it in an alternating sequence on the 10s. And then what we'll do is actually look to see, does that change the activity of the muscle? So for example, this would be a case of a person with cervical dystonia, and our sternocleidomastoid side bends at the same time, it rotates the opposite way. So what we would look for, so for example, if I had some rotation to the right, what I would look for is even active motion. Can the person get more active motion to the left with the 10s? Do they get more active side bend with the 10s? And again, what we might notice is that it makes it worse. So in that case, this level of sensory stimulation, not very helpful. So that's how we might use it in cervical dystonia over the overactive muscle. In any focal dystonia, so I had some great questions about Parkinsonian dystonia, which happens fairly more common in the leg. I'm not that flexible to put my leg up over my head to show you, but I'll show you on the arm. So, if we were looking at a focal hand dystonia, we might do the same thing on the arm and put the electrodes over the dystonic muscle, turn it on to just barely perceptible. And this depends on the person, what level of intensity that is. And then we would go do the activity, writing, typing, drumming, whatever it is that we're looking to change the dystonic muscle activity. The idea is that we're actually changing the sensory input to influence the sensory map in the brain. So that's 10s. That's how we use it. So I wanted to show you that, and I will send in our newsletter this week, if you're not already on it, for our healthcare providers, reactiveeducation.com. I'll send a link to the typical 10s unit that we use as well. Really inexpensive, so it's something that patients can buy as well. Another area of sensory input that's been shown in the literature to be beneficial and that we've used as well is vibration. And again, this can be done several different ways. We love these Hyperice vibration balls. There's 2 different sizes, and you simply just turn it on. And then this, similar to the 10s, you would put it over the dystonic muscle. And then the nice thing is the person can, on a ball, roll on it, move on it. It's really great on the calf. The ball, it works on the neck muscles, but I like the smaller ball better for that because this is pretty big. But this is what's nice also about this is they have, I don't know if you can hear that, but several different levels of vibration, different intensities and frequencies of that. And by the way, I'm not associated with any of these companies, so I'm not trying to sell you anything at all, but this is the Hyperice vibration ball. They sell lots of vibration balls on Amazon. I've had patients get several different kinds. This one, very sturdy. I do have a question here. Lower leg dystonia that pulls into ankle inversion and knee flexion. Can we put on the eversion muscles to attempt to correct during gait? Great question. So 2 different things that we might want to do. So if you have somebody who has lower leg dystonia, very common that it's pulling into inversion, sometimes also pulling into plantar flexion, knee flexion could be a part of that too. Well, then we want to test out if that dystonia is sensory sensitive. So I might actually take the 10s and put it on the tibialis posterior, for example, or the plantar flexor, and see if that responds. And I might do it during gait. I might also see if it responds to vibration on the vibration ball or a little handheld vibration tool. This is my current favorite. I'll show you that in a moment. But you bring up a great point, Lisa. You could also try NMES, so neuromuscular electrical stimulation on the everters. So in that case, if you were trying to stimulate the opposite muscle to the inversion, you might actually, instead of just using TENS, although you could try TENS and see if that helps with the eversion, you could try stimulating the everters to get more everter control during gait. Now, here's the hard part is sometimes when you do that, the dystonia kicks in a little bit more. It feels that resistance, like you're trying to activate the everters, and it actually pulls more. But maybe you're getting a sense here that it's like not a one size fits all by any means. So you really have to play around with these things to see if this could be helpful. This is one reason why a lot of people don't use bracing in dystonia, because sometimes when you feel that brace, it actually turns the dystonia on a little bit more. However, I have had people who, for various different types of dystonia, respond really well in an ankle brace. So this is very person specific, and I would, go ahead and try it. Yeah. And so Lisa's saying Parkinsonian dystonia is what it is. Yeah. So I usually try the sensory first, and I forgot to mention, so let's go on just a little tangent on Parkinsonian dystonia for a moment, because I've been getting a lot of questions about that. One of the pieces that I go to first for Parkinsonian dystonia is their medication. So the dystonia may be an on-time phenomena. It may actually be their medication causing it, or an off-time phenomena, meaning it's the medication wearing off that can cause the dystonia. And sometimes just a little change in medication management or schedule can be really effective for the person with Parkinsonian dystonia. So that's where I go first. Other key brain pieces in dystonia that I see with Parkinson's are sleep, their overall rhythm of their diet with their medication, because that can change the absorption. So lifestyle issues, this is why I think OT is so important in dystonia and Parkinson's. And then their overall exercise activity level and use of the limb. So for some people with dystonia, they're actually, that are dystonia with Parkinson's, they're really not using that, if it's very asymmetrical Parkinson's, really not using that limb as much. And so we actually may need to functionally get them more weight bearing in that limb. Now, caveat on a caveat on Parkinson's. There's also in the Parkinsonisms, there are some of the Parkinson plus syndromes that have much more severe dystonia that responds a lot less to these things. Cortical basal degeneration is one of those, or CBD for short. And if that's the case, if the person does have one of the Parkinsonisms, we may be actually having to accommodate it more. But again, even in a Parkinsonism, they can respond really well to intense exercise and weight-bearing activities. So Lisa said too, we failed bracing using AFOs. I have not seen an AFO be helpful in Parkinsonism dystonia. Success with Theratog. So that tells me actually that there might be a sensory component, because I think Theratogs can provide that kind of like positioning and joint proprioception sense. So maybe some of these other sensory pieces could also be helpful. We did TENS, we did vibration, and this is the other vibration tool that I have really liked. So we use the Hyperice version of a massage gun, but I wanted something smaller actually to take with me to New York when I do the marathon next week. And this is the one that I found on Amazon, and I've been really, really liking it. It's similar to the Theragun. Oh, I can't remember what brand it is, but it has several different tips, which I think is nice from a sensory standpoint. And this again, I would try over the dystonic muscle. So again, if I'm looking at wrist and finger flexors, I might be here. I might be very lightly, this is not comfortable over the neck, but very lightly on dystonic muscles. Sometimes in cervical dystonia, you will also get some overactivation of upper trap, levator scapula, you get some shoulder elevation, and this can be really helpful. And again, I'm all for any tool the person can apply themselves, so they don't need to see me in therapy. By the way, I'll put a link to this as well. Again, I'm not affiliated with any of this. It's just my personal one. It is the Hyperice. And I want to say I got it for $39 or so on Amazon, but I like that it's handheld, and I'm going to put it in my carry-on to take to New York for the marathon. So that's another vibration tool. Now I wanted to show you sensory mapping. So this is an assessment that goes into treatment. So again, you're going to do this over the dystonic muscle. And I realized as I was trying to show this, and like this is a really awkward angle for my arm, but I wanted to show you the grid. So for example, if I had wrist and finger flexion here, you could do this over the neck muscles. You could do this on the leg. I would actually draw a 9 grid here. And I would test out how well the person can localize over that area of skin, over their dystonic muscle. Localization meaning, can they tell the difference between spot 1, 2, 3, 4, 5, 6, 7, 8, 9, so that they can localize it. This is similar to doing kind of like a 2-point discrimination. But if you imagine, what I'm doing is kind of testing that map in their brain. How accurate is it? So what's nice is you can really progress this. So you can go to just a very specific touch and, tell me what number I am on, right? And what we do typically is take a picture of it. Then we have them not look, but they can look at the picture, so they don't have to do all this like visualization in their head, but actually look at the picture 1, 2, 3, 4, 5, 6, 7, 8, 9. And then you can progress from just doing a single point to discrimination tasks. So we might go from, is it the edge of the pen or is it the edge of the highlighter, right? So very different. And they would discriminate, okay, that's the pen, this is the highlighter, and so on. This mapping technique for assessment and treatment was actually taken from a really great article. I'm drawing a blank on the name of it, but I'll put it in our newsletter again. They did this protocol in people with frozen shoulder and had really tremendous results when they remapped the shoulder area. So this is not something that's been studied in dystonia, but for sure, this is what we have done from a testing and treatment standpoint over dystonic muscles. So I just gave you 3 here. We talked tens. So tens over the dystonic muscle. We talked vibration. So vibration ball, vibration tools, and then we talked sensory mapping. Those could be done over any muscle. Again, if you're a person with dystonia, I highly recommend you do this with a healthcare professional, because there are some contraindications for putting electrical stimulation on your body. So there you have it. That 3 different ways that you can treat from a sensory perspective, sensory input perspective for dystonia of any kind. We talked a little bit about Parkinson's dystonia because there's some unique things there as well that you want to look at from a medication standpoint and from some of those other brain health standpoints that can be influencing dystonia across the board, really. That's not just Parkinson's. And this is all, if you missed out, we've got a blog post up on our reactivept.com/blog We have a cervical dystonia assessment and then cervical dystonia treatment blog post. Really great outline to get you started in dystonia. And we have some free resources there. We have a cheat sheet for both assessment and treatment of dystonia. So really handy resources. I want you to just go out and help all the people in the world with dystonia, because people really can't get better. And I think with really great therapy, you're armed to help people and make a difference. And then again, our mini course for dystonia is coming up in November. Something that I completely forgot and have not really shared is that our mini course, we decided to donate half of the proceeds from that course to Resources for Hope, which is our partner nonprofit. Resources for Hope provides scholarships for neurologic specialty care at re+active. So we use our Brain Bites memberships. We donate half of that to Resources for Hope. We decided to do the same with this dystonia course because there's such a need. We have a wait list of people for scholarships, and we just said, well, when we do this course, let's give half of that back to people who really need it. And one of the really, really cool things that I saw as I was working on our numbers this week is that we see a lot of people in an intensive integrated program for various disorders: dystonia, concussion, functional movement disorders, Parkinson's, stroke, brain injury. And actually 1/3 of all the people that have completed those programs were recipients of a scholarship. And to me, that just makes my heart sing that we're able to help people even if there's a financial barrier. So anyway, if you are a physical therapist, occupational therapist looking to grow in dystonia and also looking to give back to help provide care for people who need it, consider this dystonia course. It's gonna be awesome. I'm so excited to do this with Chelsea Richardson in just a couple of weeks. So thank you so much. Thanks for being here. Thanks for caring about people with neurologic disorders and for really wanting to make a difference. I so appreciate you, and I will see you next week.